This session will be moderated by Dr. Corey Bradley, and then we have 3 expert implementation scientists and practitioners. The panelists will get a chance to introduce themselves as part of the questions, but Corey won't get a chance to introduce himself, so I'll get to do that honor right now. Corey was, so feel free to select seats. You don't want to be far from each other. So Corey, you can sit too. We have, yeah. And those 2 mics both work, so you can pass those along when you want to answer questions. Okay. But Corey, you can want to sit? Yeah.
I actually want to start here, but
okay, no problem. So Corey is faculty at our Center for Dissemination and Implementation Science. His primary is in medical social sciences, and then, do you have a secondary in psychiatry?
No, but
okay.
I'll take another job.
Okay. And Corey is an expert that conducts work at the nexus of health equity and implementation science. Part of why we invited Corey to facilitate this panel is that he brings a really rich and diverse background to this work, in the sense that after college, when he graduated Morehouse, he worked for as a pastor for over a decade, really serving communities and understanding their needs, before getting his MPH, I believe MSW, and then finally a PhD at Johns Hopkins, and then embraced all things implementation science. So I thought that rich background as training in clinical work, community service, really ministry, would really bring a nice vantage to this discussion with our experts. So Corey, take it away.
Thank you. Clearly just didn't have enough to do, right? I appreciate that so much, that introduction. I'm really glad to be with you and to present friends and colleagues in the work, and appreciating that origin story. One of the things that was captivating to me about implementation science is this notion of translation. And I find in ministry that was always a part of my work, right? The question of whether that was from evidence or not is another discussion, a philosophical discussion maybe. But just this idea of how we engage information, ideas, and put them into practice in our lives. And so I'm so grateful to have these rock star scholars here with us. And the way we're going to kind of flow is we'll have each of them to introduce themselves and their work, and then we'll proceed with a few more questions that I have. And then if you'll be thinking about some questions or insights that arise for you, I think that'll be great. So let's begin. And I guess, Darius, let's begin with you. If you will, just take a few minutes and describe your youth mental health research. Tell us what you do through your research. What are those important questions you address in your work? And reflect on how implementation research methods have been essential to the goal of moving effective youth mental health care into practice.
So a small question.
Yeah, okay. And also see if you can fix the whole world in about 3 minutes. So.
Appreciate the opportunity to chat a little bit with all of you. And I feel like I need to describe a little bit more, perhaps, about the work that we do, because we do touch on youth, but maybe in slightly different ways. Our lab, the Mothers and Babies Lab, we are very interested in preventing postpartum depression. That is the focus of our work. The connection with this conference and youth is really twofold. Number one, a lot of the families we work with, a lot of the pregnant individuals are youth. So depending on how long you define youth, 18, 24, we have many youth that we are working with. And also, we also think of our work as being sort of 2-generation focused, right? If you are addressing maternal depression, you are then able to, prevent, a whole host of sort of negative cascading, poor child developmental and behavioral outcomes. So just wanted to sort of contextualize that. The work that we do, I think, has changed quite a bit over the last few years. Prior to 2019, we had done a lot of clinical trials to determine the effectiveness of our intervention. And in 2019, there was a report put out by the U.S. Preventive Services Task Force that reviewed effective interventions for preventing postpartum depression. And our intervention, Mothers and Babies, was called out as one of the 2 most effective interventions. And I'm not exaggerating to say that since that day, our phones have literally been ringing off the hook. people wanting to implement our evidence-based intervention. So prior to 2019, we had done some training, some technical assistance. We're fledgling implementation scientists. And, you know, I kind of think of our work as really having two eras. Thank you, Taylor Swift. You know, we have the pre-U.S. Preventive Services Task Force. My wife would love the fact that I built that in. So we're pre-2019 Task Force report, where I think we did some of the things you saw in the keynote. But if we did them, we didn't do them systematically. I don't think we did them as thoughtfully as we are doing now. So I think that moment in time really allowed us to think much differently about what we're doing. And just so that I'm not talking too much, if it's okay, Corey, I'll sort of share some of those specific examples of how we've sort of pivoted a little bit later and let my colleagues spend a little time introducing themselves.
We'll let him for that. Thank you. And can we just welcome him? Thank you with the, yeah. We appreciate you. Renad, picking up with that same question, just help us get familiar with your work and how you think about how that work advances implementation methods and the impact of implementation in advancing youth mental health care.
Well, thanks for having me. I'm going to follow Dr. Tandon's lead and kind of tell you my origin story about how I came to be an implementation scientist, and then can get into some of those weeds as we have our organic discussion. Riffing off of Dr. Moore's talk, I think that my North Star, if I were to go back to even when I was a little person, was that access to high-quality health care is a human right, and that everybody should have access to high-quality health care. So I found a poem that I wrote when I was 10 years old. My dad is a physician. He was working on the front lines of the HIV epidemic in the 80s and would tell me stories about his patients. And the poem was all about insurance and making sure that everyone had access to high quality care. So, you know, it fits the story. I will show you all the poem, I promise. It's a little too rhymey, but it's still, I think, helpful to look back and see that this has always been a driver. I went to graduate school thinking that I was going to be a trialist. I worked with Phil Kendall, who's the developer of the Coping Cat. And when I got there, the treatment was kind of ready to go, but we were still doing lots of trials. And clinically, I noticed that a lot of the kids that came to the clinic had seen other therapists in the community and hadn't gotten access to CBT for child anxiety. And so I did a major pivot, and I went from thinking I was going to improve cognitive behavioral therapy more to help the kids who weren't responding to treatment, to really going all in on implementation science. So I drank the Kool-Aid. I think it's an incredible method and tool that can help us achieve that North Star that I was describing earlier. And I will say that I made the sin or the error early on in my implementation science journey, thinking that training was going to be the answer to why therapists in the community weren't using CBT, and it was very humbling. I'll say doing implementation science work is so humbling. But that's my origin story. I can talk a little bit more as we go, but I do work across lots of different disease areas, but youth mental health as a child psychologist has always had my heart. Our work in that space has focused on generally CBT for kids, TFCBT, and more recently a lot of work in suicide prevention for youth.
Please help me thank and welcome Renad for her comments. Thank you for being here. You know, we can't underestimate the power of applause, because this is some tough work that we're all involved in. So just, it's a way of saying thank you for staying in the fight. Yeah. Colleen, what can you tell us? You are a unique individual for our panel, just because you are that other side of the bridge, I think, do work in advocacy and helping to make that connection from the other side, perhaps. But let's hear from you how you situate implementation work in advancing youth mental health care.
Sure, thanks. Can you hear me?
Let's choose that one.
All right. Now you can hear me? Awesome. Well, I feel like I should follow the path of my colleagues and share a little bit that my story of how I got to where I am today, because I was a graduate student here at Northwestern, so I came here to learn the top-notch clinical interventions and deliver them in intensive treatment settings like hospitals, partial hospital programs, and inpatient units. So that was where I started my work, and have always been interested in trauma and the impact of experiencing adversity and how that shows up in lots of different settings. And I've been at this institution now for almost 40 years and have switched. So I believe very strongly that we do have the answers, as you mentioned, to what to do if kids have experienced trauma. And if you come to our institution, you will get fantastic treatments. But the fact of the matter is most kids never get there. And so what I've done for the last 20 years is to pivot from providing evidence-based interventions to saying, how do we expand the number of adults who can be part of the process of promoting kids' mental health? So very similar to some of the work you were describing in California, I am part of a team, so if you're part of the Center for Childhood Resilience, please raise your hand. We have a growing team. We've just recently recruited several fantastic research colleagues who are much more embedded in the language of implementation science than I am. I think I am someone who was doing this work before anyone even had the words to describe what we were doing. So I'm learning all the time, and I created all kinds of great talking points, but I think what I'm going to say today is that I run something called the Center for Childhood Resilience. Our work really is this intersection point that says, okay, how do we function as an intermediary between all of our colleagues who've created these amazing interventions that we know work and the systems that need to be brought along to help implement those things. And so we do that not so much by focusing on kids, but by focusing on adults. Who are the adults in kids' lives, whether it's teachers, parents, coaches, Girl Scout leaders, ministers? Who are those adults, and how can they collectively help promote mental health and wellness for kids? And when there's a need, bridge their relationship with those kids to get them the help that they need where they are. So getting the right intervention to the right kid at the right time, delivered by people who they trust. So I already got my favorite line taken earlier because I say that all of this work is all about relationships and trust. And the idea that any implementation moves at the speed of a trusting relationship is absolutely essential. So our work really is looking at how do we do that. We started, the answer to the question of how do you show up? I will tell you, you just keep showing up, and you show up again and again, and eventually you're that curly-haired trauma lady from Children's that keeps showing up, and she must have really care about us because she keeps coming back. So it's coming back again and again with different asks, different resources, blending your funding. I know we all want NIH funding, but I can tell you blended funding is critical because that's how you go in and you build relationships. If they're asking you to come in and do a training, go in and do a training. They ask you to come in and talk about bully prevention, my favorite drug to SEL, because there is no good bully prevention unless you're talking about SEL. We can't go in and just address the problem. We have to go in and teach kids how to get along and socialize. But if you call me and ask me to do bully prevention, I'm not going to tell you that it's a bad idea. I'm going to say, let me talk to you about what you're doing and what is already in place in your school and how do we help you be successful. So building those relationships is absolutely essential for our work. And then what's happened is the relationship that we've been able to do because we keep showing up in Chicago has translated to us being invited into tables in other places. So now we're doing statewide work and national work. We can't keep showing up in those places in the same way. And in fact, people don't trust Northwestern and Chicago and Lurie Children's and the Pritzker Department of Psychiatry, which happens to be named after a governor who happens to be Democrat in Southern Illinois. So all of the reputational work that we had to do the work and keep showing up in Chicago doesn't exist when we move outside. So we have to lean in even deeper to those qualities of showing up with humbleness, showing up and saying, we have some ideas about what works. We know this works, and if your kid comes to our hospital, we'll help them. But what we don't know is you, your system, and your needs. So how do you partner with us so that we can actually bring in things that work with you, for you, and if there's not something out there, then we spend the time creating those new interventions to help you meet the needs of the kids who are sitting in your communities. But it's a lot, and we do it at multiple levels, and we're doing it embedded within the structure, like you were hearing, of regional offices of education, the State Department of Education, the federal dollars that come in from emergency crisis response and then they go away. We're doing it with partners across the state and saying we can be the intermediary, but we're a collective. So even at Lurie Children's, we need to lean into our colleagues from Southern Illinois to be our partners and translate. We need to have those folks who can show up more regularly. So that's the work we're doing. We're growing our reach and impact by using implementation science, and I really appreciate having more language to describe what it is that we've been doing, but also really excited to see the growing interest. The sadness that you couldn't even use those words in your dissertation makes me sad. So all of you that are graduate students now, go ahead, use those words. We like them, and super excited to talk to you today about the work that we're all doing collectively.
Colleen, for the truth-telling. Thank you. You know, I wanted to build a little bit, to your point, one of my kind of favorite implementation theorists, Carl May, in normalization process theory, talks about implementation processes are about collective action and collaborative work. And so you're beginning with that participatory engagement that's so it's such a feature of implementation research. I want to maybe pick up from that and Julia's comments about the relationship pathway. How do we think about youth and families, given that they're embedded in multiple kinds of systems? How do we think about implementation work, implementation inquiry? How do you situate that in your work, dealing with all those multiple levels? And this is just kind of open if anyone wants to just begin talking about that.
You want to start?
We know that would work.
Yeah, I mean, I think the work that we do, I mean, we train a lot of community-based providers, home visiting programs, early childhood providers, and I think one of the things that we learned very early on was we have to have relationships with multiple levels, multiple individuals within, the setting, the context we're working with. What happens oftentimes, at least in our experience, is somebody will hear about our intervention. It might be, an agency director. It might be like a state superintendent of early childhood, and they get really jazzed about it, and they say, let's do mothers and babies. Well, that's great. Like, we've got their buy-in, but then we need to make sure that the supervisors at these programs, the home visitors, the line staff are also bought in. So I think initially we didn't give as much attention to really building those relationships and understanding from the perspective of all of those folks what we need to be doing. So I think that's a major learning. And I think in the last few years, we've done a lot more to make sure that we have both initial and ongoing connection with all of those folks. And I think that that's made a world of difference.
So relationship building is the bedrock to implementation science. If you're not going to do that, it's like a no pass go. It's not going to work. You're going to be frustrated. The people you're working with are going to be frustrated, and it's not the right way to go about it. I'm not usually black and white around, right and wrong, but like in this case, there is no forward path. PCORI just released some really helpful guidance around what it looks like to have, thoughtful and intentional community engagement and relationship building. And I think intentional is a really important part of this. So I encourage you, when you think about doing your work in this space, to do a constituent analysis to understand all the different types of folks who might be impacted by your implementation in youth behavioral health, including the youth, and make sure that those voices are centered. I think that's what's so powerful about implementation science, is that we can use it as a tool to empower folks and to shed a light to what's happening within the context of our communities. And I just want to come back to that point of humility. When I first started doing work in the secure firearm storage space as a universal suicide prevention strategy for pediatric primary care, I did what I thought was a comprehensive constituent analysis, and we did lots of interviews with the different kinds of folks who might be impacted by implementing a secure firearm storage program in pediatric primary care. And as I started talking to firearm-owning parents, leaders of health systems, primary care doctors, advanced practice providers, I realized that we had left out a really, really important constituent group, which are firearm safety experts, firearm rights advocates. That's not a group whose voice is usually amplified in the public health space around firearms. And it was really important that we had those conversations and we built those relationships. And I think that's why we've been so successful in our efforts to implement this secure firearm storage program at scale. So I encourage you to think hard, intentionally, and to iterate as we do in implementation science around making sure all the right people are at the table alongside the whole process.
Yeah, and I love that so much, this notion of bringing partners together and folks to talk who probably would have never talked, right? And I think there's a sense of empowerment, an opportunity for empowerment and building power among those groups. Colleen, you have any thoughts?
Yeah, I would say similarly, this idea that there's usually, in our case, a school social worker or a school psychologist who hears about something and wants to learn it and comes to a conference and gets all excited and then goes back and is just not able to implement. So what we have seen again and again is definitely the multi-layers. You've got to get administrative buy-in first, and you've also got to be transparent. That even if you're doing a 10-week group, it's not 10 hours of time for that clinician. It's for them to do the planning, the training, gathering the group, figuring out who the right kids are for the intervention, and they have to get buy-in, which means they have to not wear the walkie-talkie while they're doing the group. Because schools are kind of used to social workers being available 24/7 to deal with the crisis that just walked in the door. And it doesn't matter if they're in a meeting. But if they're running a group that has an evidence base that has to be delivered with fidelity, they really need an actual door closed, you can't interrupt me, and that means changing school policies. So the administrative problem solving and getting them to understand why this is important, I think language is absolutely essential, and having evidence that says, I did this in this other school, do you want to talk to a principal who did this? Goes a really long way. I also think I want to just add youth voice. I think we have really come a long way with stigma reduction in our young people. And so when you have adults that don't want to do something, that are afraid of change for whatever reason, if young people are the ones telling them they want and need something, it's a lot harder to ignore. So we have really been lucky to elevate with some great leadership on some members of my team. Really, what does it mean to really use opportunities to elevate youth voice, to pay them for their time, to coach them on how to do the research, ask the questions, turn their ideas into public kind of talking points, go out and talk to groups of adults. And also, just like with your partnerships in the work itself, stay there and be those stable adults in those kids' lives, because if we can get some of those young people who are excited about mental health and talking about it now into the field, we will all benefit. And many of us had people who helped us along the way, and those high school students who were part of a advisory group for some study of yours who call you up 2 years later and say, I'm thinking about going to graduate school, can you help me? That's a game changer. So it's elevating them, it's being those constant supports and really saying your voice matters, not just because it's kind of politically correct, but because it really matters and that adults are going to listen.
Julia also talked a little bit about this notion of equity, health equity, embedded, baked in. When I first arrived at Northwestern, talking with Ron about the program for public health, we talked about health equity as its initiative and moving that forward. And one of the things I thought he said that was really powerful was, we want it to be in such a way that you wouldn't even have to name it, but know that it's happening, right? I think that's so important. We talk about in sustainability, it's the disappearance of practice because it's so routine. So this question is a little bit about health equity, given that the conference theme, particularly around access, has been named. And though it's been framed as controversy in the current state of affairs, along with several other scholars, we know that the goal of health equity, our sense is that the goal of health equity is fundamental to implementation research. So how have you been able to leverage implementation science methods and inquiry to ensure that evidence-based treatments reach diverse, underserved youth populations and their families?
That is basically what our team's that's our North Star, right? So I guess.
Are there any specific projects or anything, ways that's shown up for you?
I mean, I think the North Star of saying that healthcare is fundamental right and that mental health care is part of healthcare is absolutely the North Star, and we all believe that in this room. But the question of recognizing that literally the kids least likely to get mental health services that have any evidence that they work are Black and brown kids and marginalized kids in our world and our communities is true. Period. Done. So we know that the kids who make it to our hospitals and our evidence-based intervention, lovely programs that are very specific, et cetera, are people who have resources and adults in their lives who can get them there. So when we talk about going into schools, or right now we're looking at a partnership with Chicago Parks District, these are places where kids are. Kids are going to those spaces. So how do we try to translate those places into those safe spaces where kids can have their mental health looked after and guided and supported, or when those people aren't able to meet their needs, they have trusting adults that will get them linked to the services. So from my perspective, all of the work that all of us are talking about today is about increasing access to evidence-based interventions. One stat that you hear is that about 50% of kids who need mental health services in our country are getting them. We think about 50% of those, the only mental health professional they'll ever see is not any one of us, but someone who's sitting at a school counselor who may not even have had a CBT course in their graduate program. So we're going out there and saying, hey, do this great manualized treatment, it's awesome. And they're like, I don't know what you're talking about. I don't want to do a manual, that's not therapy. So we've got to be addressing all of that and changing the thinking and having them understand, yes, you're right, tell me about what you don't like about CBT. Let's hear what your concerns are, and then let's help you practice so you can see that it actually works, and showing up beyond that train and pray like you mentioned, but being there for supported implementation and saying, oh, you tried that and it didn't work? Tell me what you tried. Let's figure it out. How can we make it work? So the equity comes from I think somebody said it, like, it's not, readiness is critical, but if you're not ready, it doesn't mean that you ignore them. It's that you say, what are we going to do to help you get ready? What are those barriers? What do I need to do? Where do I go back? If it's teaching the counselors that CBT is actually evidence and they should use it, if that's where we need to start, that's where we start. But it's really thinking about, first and foremost, when we're looking at federal dollars or we're looking at grants, we need to prioritize those schools that kids are going to have the least access to mental health services.
I couldn't agree more. I don't think there's a path forward for implementation science without explicit and intentional attention to equitable implementation. So just coming back to that point of, I was just speaking about in the last question, is at the start of any project, we want to ask ourselves about how we're integrating an equity perspective into our work. Typically, I see kind of two types of projects. Projects where you're explicitly trying to close an inequity that you might see in a community. And then projects where you want to make sure that you're not creating or reifying new inequities. And so I think it's really important to have that lens and to, at the beginning, ask those questions and then continuously track to make sure that you're centering the intersection of equity and implementation science, which Dr. Bradley is an expert on. And so I'd also like to hear his thoughts as we go across this line.
So I'll tackle it maybe a little bit differently. You know, when we think about equity, we're really thinking about all of the various perinatal populations that could benefit from our intervention. And they're very diverse, you know, folks that are sort of reaching out to us. So, you know, we're mindful. We don't want to be creating 43 different adaptations of mothers and babies. But one of the things that we are very direct about with our service providers is we want them to be thinking about how to adapt, and we give them a lot of guidance. You know, we've developed a tool where we basically say, here's a red light, yellow light, green light in terms of things you can do or can't do, and I think that's been helpful. But we also have, you know, taken on, you know, very, you know, explicit adaptations. We've done work in partnership with tribal home visiting programs to adapt for tribal home visiting programs, you know, working now with SGM populations. So I think, you know, we're trying to think about ways to make sure that, you know, the material is really going to, you know, resonate with the various populations that we're working with. And the other thing that I'll say is, you know, another sort of big, you know, way that we've tried to address this sort of equity issue is going back to this point that there are just not enough mental health providers. So a lot of what we are doing now is really thinking about task shifting delivery of the intervention so that lay individuals can deliver mothers and babies.
Yes, I really appreciate you bringing that notion of adaptation, and if anyone has any, so Renad is the expert over me, right? But I would say, I mean, you know, question maybe if you have any reflections on this tension that's sometimes held around Darius, if you want to continue adaptation and this commitment to fidelity and making sure that the intervention is working as it's supposed to. Have you had to deal with that tension, or do you have thoughts about how we approach that?
I'm going to say something that former Renad, when I was a graduate student, may have been like gasping about. I don't get so worried about fidelity in its strictest sense. I think that we have to move away from that. I think Dr. Moore's talk gave us one of the 7 lessons is that we must think flexibly. And so I think, to Dr. Tandon's point, this idea of being clear about what's core and what needs to remain, because it's a mechanism of how the thing works, but how it can change in form but still meet its function is a really valuable one.
Yeah, thank you so much for that. And, you know, to respond, since you responded to my question, I think, you know, the space, one of the spaces around health equity is bringing in interdisciplinary knowledges, right? You know, folks that know, if you know, you know, implementation science has its theories, models, and frameworks, and I'm always trying to break them. Not break them for bad, but expand them, right? Because, you know, there are other opportunities for learning and for scholarship. So that's one of the spaces that I think I've pursued is how do we expand the question? How do we deal with agenda setting? Who says it's a problem? It's a question. Who says it's even evidence? And how we negotiate that in the process of doing and making implementation happen. So those are my thoughts there. We are nearly to our time, and I want to open up for folks to ask questions. If there are any questions ready, I do have more. You know I came ready. But is there anything that maybe has not been addressed or something that was spoken that you'd like to hear a little bit more about? Yes.
I'll try to project. So one of the things that I often hear in multidisciplinary conferences is, I understand that there is a behavioral or psychosocial intervention, and you are showing some evidence that it not only works in a controlled environment, but you're beginning to do dissemination. How can you train lay people to do it? And I worry very much about that question because there is some level of behavioral health or psychosocial training and expertise. And if we disseminate our intervention so that it is only lay people that are providing it, but it requires some kind of foundational knowledge of psychosocial processes, what are we doing? So I would just love to hear, I'm worried, but I don't exactly know why I'm worried. So I would like to hear the panel maybe address or talk about this issue.
I cannot summarize that well, but for the people on Zoom, this was a question from Jill Benchel Weiss about this tension of ultimately wanting treatments delivered by lay folks, but also wanting to evaluate them when delivered by lay folks, and navigating that tension, because getting them to deliver it is a challenge, rife with challenges, and can create concerns.
So I might ask a question back, which is why are we worried? And how do we expand the kind of workforce to meet the need? Because there's never going to be enough of us. And I don't even know if there were enough of us, if that would be enough of us, because I don't know that that empowers our communities, right? There's so much emerging evidence, strong evidence about the effectiveness of community health workers. There's great work coming out of the global setting around lay individuals delivering CBT. To me, if we could develop a multi-tiered approach to meet the mental health needs of our world, I would be thrilled. That to me is the North Star, because that gets us access. Now, I think the reason we're worried is because we're worried maybe about quality or dilution. But I think if we create that infrastructure that Dr. Moore noted in her talk, and support people, help people in places do the thing. That's what we do as implementation scientists. Then I think we get closer to our vision and North Star, and we don't have to worry.
I would just add, I think that creating pathways and certifications are really important. I mean, we all are here at the highest level of education, but we need to be thinking about those high school kids that are going to community college that are interested in mental health, and how are we helping them to develop some skills that can get them employed, can get them helping their community, and then ultimately, maybe they'll decide to become clinicians, or maybe like many of us, they'll change tracks and won't be the educator or the pediatrician I was gonna be, right? They'll figure it out. But if we can start with thinking about the workforce development at multiple layers, and I do think that the work that Dana Weiner, one of our former colleagues, is leading in the Children's Behavioral Health Transformation here in Illinois, one of her big areas is thinking differently about the workforce. And so we are doing a lot of work at looking at who are those people who are mentors in young kids' lives? Who are the substance peer support folks that are working in that world? How can we start to create a set of coursework so that people can get the skills that they need to do the interventions at the level that they're doing them, and also know when they need to ask for someone to get more help? And so when we talk to educators, this is our line. We are not trying to make you into a mental health provider. Period. Stop. That's not happening. But we believe you know kids really well. You have relationships with kids. You understand child development, and you have a lot of kids, a big sample, so you can tell when a kid isn't like the other kid in your class. Help us identify what the kid needs early and ask for help. So to me, it's the creation of a pathway and things like extenders, right? Like if you're doing work in your own field around exposures, you can only see that kid for 45 minutes once a week for insurance. But what if we had a whole army of bachelor's level people who could go with that kid and do all the stuff they need to do that they're afraid of multiple times a day or multiple times a week? They are going to get better faster. So I think it's us stepping in and not ignoring that we have to be part of this, and we can't hold the skills, but we need to think about it and create mechanisms and pathways to do that, and layers of supervision and support and pathways, so that if you're that kid who can't pay to go to college right now, but you really love kids, you might start as a community health worker, and then you might learn about some things, and you might get a certificate, and then you might get another one, and then before you know it, you're in graduate school in social work. But it didn't start there because you could not see that pathway for yourself. So it's really being more clear about what we are doing, and it's that multi-tiered system of support that public health talks about all the time.
I think that the metaphor of the bridge is powerful, and I think we tend to think about it from research evidence to practice, and we don't think about that practice needs to inform what we think we know, or how we come to know. And so I think that that's a really powerful opportunity for us when we think about that. Darius, did you have anything?
I'll just say that I personally wasn't concerned with the question that you raised, Jill, but many of my psychology colleagues were. I mean, they looked at me like I had a third eye when I said task shift, lay professionals doing our intervention. So another way that I'll answer your question is we actually did a study. We did a non-inferiority trial. We compared clinicians with paraprofessionals. And we found that the paraprofessionals delivered the intervention with similar fidelity. They got similar results. So, I mean, you could also generate evidence to demonstrate that they can work, right?
Yes. Oh, yeah, sure.
This is great, guys. Thank you so much for doing this. If adaptation is the rule and not the exception, can you talk a little bit about what that means about the evidence base and our existing evidence-based interventions? Does it mean that we've built evidence for interventions that are not implementable fundamentally? Or does it mean that whatever we build evidence for, we will need to adapt because by its nature, it will always need to be implemented in different settings?
Ooh, controversy.
So I think that for a long time as interventionists, we were not building things that could be deployed in the community. I like to show this slide with the impossible teapot, which has like the spout and the handle on the same side. It's really pretty to look at, but you don't want to use it because you're going to burn yourself, right? And so I think that for a long time we were developing interventions not for the context in which they were meant to be delivered. And we have a provocative paper that we wrote about how the true test of an intervention is in context. And so I don't actually really care about the efficacy studies. I care about whether or not it can work. You may not all agree with me. That's okay. We can have a debate over coffee. But I think some of the great advances that have been made in recent years in bringing human-centered design, thank you, Dr. Graham, for all your contributions there to make our interventions better, bring us closer. I actually think implementation science and intervention science are coming back together, like they're going to get married again. They separated for a while. We used to be together, right? And I was in Phil Kendall's lab, and he was like, training is part of the coping cat. And I was like, no, training is an implementation strategy, and we had to work really hard to disentangle what the strategies and what the interventions were, but then we went on these kind of parallel tracks. Now we're coming back together. That being said, I think you're always going to need to adapt an intervention for new contexts, new populations, so I don't think our work as implementation scientists is going to go away, but it might be a little bit easier if the things that we're actually trying to deploy are things that our community wants.
Yeah, there's a paper, I think I have right, Ross Brownson and colleagues did something kind of talking about how to frame evidence and what implementation science, how we need to kind of negotiate our understanding of evidence. And then Tim Rhodes and Kari Lancaster, they have an expression or articulation, or they resist the notion of evidence-based and refer to it as evidence-making. And that I find that gives me a little more capacity to think about that it's not final, right? What we call evidence, and evidence can be contested. And so the work of implementation science for me is negotiating that space. Yes.
Renata, I wanted to follow up on something you said, but everybody's welcome, and that is, it seems that, so the core, knowing what the core components is essential. And I find that aren't those easy to find. It's not like always described well, and I wonder if for purposes of adaptation, in thinking about core components, one doesn't also think about, is the component adaptable itself? When isn't it? It just seems like the interventionist could really help implementation if they're thinking very deliberately about the core components. Is that happening now? Thoughts?
So I agree. I don't think it's always well delineated, but I think it's our job, if it's not, to figure it out and to work with the interventionist to fully understand that. But in a perfect world, perhaps the reporting guidelines for interventions would include some specificity around what's core, what's peripheral, and then the other concept to think about here is form versus function. So the core is what that thing is doing. It doesn't need to look exactly the same way depending on acceptability, feasibility for a context. But I'm not sure that I see folks writing up their interventions in that way. So it does create additional work.
Yeah, I also think it goes back to the idea of starting with a community request for what they're asking for. So we have lots of interventions in K-12 that are, you deliver them in a certain order, and this is the way it goes. When we started working with early childhood, the early childhood providers basically said to us, we don't want a curriculum, can't do a curriculum. We want what we're going to call a plug and play intervention. And my heart starts to race because I'm like, plug and play, and that means you can do it in whatever order you want or however you want or use pieces of it and not other pieces. And the fact is they said we won't do a 12-week intervention. And so we had to listen. We had to distill what were the main things. We had to teach them how they could exist independently, and also how much better it is if they do it all collectively and how they can set that up for success. We used some different kinds of strategies. We used momentary assessment to find out what they were actually doing, right? So some of it is also we have to change, we have to listen to what they're asking for. We have to change the questions and figure out even more explicitly what is the core components. Because I think we have some core components, certainly in the CBT for trauma world. The question of, for example, do you need a trauma narrative? Big question. I was trained, you need a trauma narrative. I can tell you we're doing lots of trauma work right now, there's no trauma narrative. So I can hold on to seeing that, and I still in my heart of hearts hope every kid can do that at some point because I think it's important. But I can't say they're not doing trauma intervention if they don't do that. I need to say it's a different type of trauma intervention, and maybe it'll set the pathway for that child to eventually get a different type of intervention. But part of it is kind of separating out what is essential in our world and what is essential in the world of the people who we're trying to actually get to do this. And if they are only doing the thing that's try to use, we have a lot of, the favorite one for our early childhood educators is a safe, calm corner. That's, we built one of those in our partial program 20 years ago. Everybody needs a place to go calm and self-regulate. And if that's the only thing they use in that preschool classroom and it causes less physical injury and more happy teachers and more parents not getting called at work, it works. But we got to then figure out how to study how it's used and figure out what are the other things that are critical. But it's a shift, I think, in who our audience is as well.
We think we have time for one super quick question from Julia.
Okay, so this is a big question I've received twice in the past month, which is, if our goal here is to have evidence-based mental health treatment and programs available for everyone, scaling evidence-based programs, the math is not on our side, right? Like, to truly get there, the math is not on our side on how long it's going to take. And do we need a paradigm shift? And do we need to think about this in a totally different way if that is the vision and the North Star that we need to get to?
We have a panel about that later today called The Future of What the which is all about the future of what the field needs. So maybe you can answer briefly, but we have 2 minutes.
I mean, for me, it goes back to that kind of multi-tiered approach that we were just talking about. I mean, we have digital mental health solutions. We can have other folks who aren't traditional mental health providers. I mean, when you say a paradigm shift, like, this isn't a good example anymore, but like, how do we make mental health like fluoride in water? Again, not a great example anymore, but that would be the ideation that I would want to do to like think about that. So I don't know. Those are my thoughts.
Well, wonderful. Are there any not last words, that sounds strange. Anything you'd like to, maybe like advice or anything you want to offer to the audience before we conclude?
I started being a fledgling implementation scientist. I'm now, I don't know, like more than a novice. So I guess, I sit here in front of you and I have major imposter syndrome, but I do feel like I've learned, and listening to the keynote, I feel like we're actually doing some things right. So you can grow, you can develop your programs to integrate implementation science. I think we are an example of how we've been able to do that.
Oh, beautiful.
This is a great place here at Northwestern to incorporate implementation science into your work.
Yeah, BB, see this. All right. Thank you all so much. That was an excellent way for us to conclude.